Henock, we are looking forward to your talk.
Okay. Thank you for the nice introduction, Dr. D. So I brought some clinical cases and also some pathophysiology and patient approach, the management, and so on, because it's different type of background. Some of you are from the basic sciences, some of you are from radiology and cardiology. So what I'm going to talk is about some of the manifestations of coronary artery disease. So basically, the commonest cause of coronary artery disease is atherosclerosis. We know that. So coronary artery disease can present in different manifestations. Can present with common presentation with chest pain, which we call it either unstable angina, non-ST elevation MI, ST elevation MI, or patients they can present also with heart failure symptoms, or sometimes they can present with arrhythmia, ventricular tachycardia, ventricular fib, which they present if they make it to the hospital with sudden cardiac death. But for today, the cases that I picked are what we call is the acute coronary syndrome, the unstable angina, non-ST elevation MI, and ST elevation MI. So acute coronary syndrome encompasses unstable angina, non-ST elevation MI, and ST elevation MI. Unstable angina and non-ST elevation MI, their presentation is the same. They present with chest pain, typical chest pain with relation to the arm, occurs on exertion. If the ischemia is bad enough, it may manifest with cell necrosis. We showed up with biomarker elevation on the cardiac enzymes. So the difference between unstable angina and non-ST elevation MI is basically biomarkers. So it shows up on the cardiac enzyme with the elevation of troponin, CK, and CKMB. But they can have TOE inversion, ST depression. ST elevation is a different animal, and its approach is a little bit different. Basically, there is no flow. There is no flow to the myocardium. That means the artery is completely occluded. So the approach to ST elevation is different than the other unstable and non-ST elevation MI. And so this is, the basic anatomy of the coronary arteries. It comes off from the base of the aorta. We have the right coronary sinus gives to the RCA, and the left coronary sinus, left main, it branches out to the left circumflex artery and the left anterior descending artery. So this artery supplies most of the left ventricle, and it goes up and wraps up on the apex and makes some, actually can give collaterals to the right system when you have obstruction here. This is the PDA of the right, and the circ goes to the lateral part of the heart. It has some autism marginal, and there is overlap on the supply of the myocardium between the diagonals and the OM. So this is the basic anatomy of the coronary arteries that supplies to the myocardium. So acute coronary syndrome, we have over 1.5 million admissions a year in the United States. Most of them are the unstable angina, non-ST elevation MI, or we can call it non-STEMI ACS, about 1.4 million, and 0.33 million are the ST elevation MI. So 2/3 of patients with unstable angina have evidence of elevated cardiac enzymes. So these are the definitions: unstable angina and STEMI. The difference between the two is only biomarkers. STEMI, they have ST elevation MI. That means there is no flow or reduction in significant flow. So what's the triggers for acute coronary syndrome? There are triggers of plaque rupture. So it could be hemodynamic stress, high blood pressure, tachycardia, or it can be sometimes vasoconstriction and inflammation. But plaque rupture or fissuring can be triggered by increased shear forces and sudden change in pressure or tone. So I have, so this is plaque. As you can see, the lipid core plaque. So the difference, what we call it stable plaque and unstable plaque, is one is the lipid core and the fibrous cap. The fibrous cap is thin, and this can be easily disrupted. So if you have disruption of the fibrous cap, the lipid core is exposed and it attracts platelets, and this is what we call it, that causes instability of a plaque. So it can cause unstable angina, non-ST elevation MI. If it shuts down completely the artery, it manifests with ST elevation MI. So here is the plaque rupture. So when you have plaque rupture, patients present with ACS, they can have chest pain. If the blockage is bad enough, that can cause cell necrosis. You have elevated biomarkers. If it occults the artery completely, then you have ST elevation. So basically, the basic mechanism is ulcerated plaque rupture. When the plaque ruptures, it attracts platelets, and the plasma is also involved with coagulants, and you have thrombus here. So this is on angiogram. This is what looks like ulcerated plaque. This is on IVUS. That's what it looks like, ulcerated plaque. You can see. So when we have coronary syndrome, we have also angry platelets. You see, these are the normal platelets. When the platelets are activated, they look angry. They have pseudopods, and they aggregate, that cause the thrombus formation. So when we have thrombus, we have different components in the thrombus. We have the platelets, we have the fibrin, we have the thrombin. So in our armamentarium to treat acute coronary syndrome, that's why we put patients on antiplatelets, antithrombins, whether it's direct, indirect, and sometimes also fibrinolytics in the case of acute ST elevation MI. So this is thrombus. So how do we approach patients with acute coronary syndrome? It's the traditional approach with history, physical, EKG, chest X-ray, and biomarkers. And history and physical is critical, and then when they hit the ER, we do EKG. And the first thing we do is to make sure that whether this is ST elevation MI or non-ST elevation MI. If ST elevation MI, because time is the essence, we activate the cath lab and we take them for reperfusion. So we first determine if there is having ST elevation MI, check for ST elevations on the EKG. Most of the time the EKG tends to miss subtle ST elevations, especially if it's in the inferior leads, and sometimes it overread when it's repolarization or pericarditis, and patients with STEMI, they need emergent reperfusion. Reperfusion, i.e., in our setting, we use balloon-based reperfusion, angioplasty stenting, but in areas where they don't have cath lab, they use thrombolytics. So either balloon-based, catheter-based, or thrombolytics. So if the patient is not having ST elevation on EKG, check for dynamic EKG change, and we do the biomarkers. As you know, troponin has prognostic value in terms of days and MI, and it's very sensitive and specific biomarker. So it's more sensitive and specific, stays in the system for 10 to 14 days. CK-MB, less sensitive and specific, help for the diagnosis of reinfarction. So as you know, as you see, the CK-MB comes early, but the troponin stays at least 14 to 14 days in the system. And there are some conditions that can give us some biomarker elevation. That's what we get consult most of the time. patients with PE, CHF, chronic renal failure, sometimes chronic LVH, or chronic coronary artery disease. Sometimes we may get some elevation of cardiac biomarkers. So we have to keep in mind there are other conditions that can give us elevated biomarkers. So the general treatment approach to ACS is oxygen, morphine for pain, nitrates, aspirin, heparin, P2Y2 inhibitors, beta blockers. Then we will decide whether we take the patients right away in the case of ST elevation MI, or treat them on ACS protocol and take them to the cath lab, what we call it invasive approach, within 24 hours. Or some of the patients, if they are low risk, we can risk stratify them with stress test and so on. So this is going to be the first case. This is a case we consulted over a week ago. 51 years old white male, homeless patient. Initially came in with auditory and visual hallucination. So he was admitted to the ICU with DTs. After 4 days, he developed nausea, vomiting, abdominal distension. He was diagnosed to have small bowel obstruction. They took him to the OR, and except signs of there was no any mechanical obstruction, and they placed angiotube for suction, and he was transferred to medicine team. And then he developed some fever, UTI. He was treated. The day he was supposed to be discharged, he developed chest pain. And we got consulted. This is the EKG we got. These are classical EKGs, we call them for especially the left anterior descending artery, deep T-wave inversions in the anterior and lateral leads. Sometimes the T-waves are biphasic. This is what we call it Whelan syndrome. So if you see this EKG, this patient has ischemic coronary syndrome unless proved otherwise. So there are other conditions that can give us this EKG. One is intracranial bleed. We see it in patients with intracranial bleed, and sometimes patients with LVH. But this is proximal or mid-LAD lesion. We had hard time to convince the patient for the heart cath. The first time he refused, and the next day we went back again to convince him. We couldn't find him in the floor. Actually, we had to find him outside the building on King's Highway with his heparin drip, and he said he doesn't want to have the heart cath. And then after a couple of hours, he said, he spoke with his family. He agreed for coronary angiogram. So this was the EKG during the first admission. So you can see the change, the deep T-wave inversions on the anterior and lateral leads, and this EKG was except signs tachycardia. It was normal EKG. So he was put on ACS protocol. Of course, we put them on dual antiplatelets, aspirin, ticagrelor, or Plavix, heparin, and we did coronary angiogram. And I'm going to show you the coronary angiogram. I hope this thing works for Shibang. Huh?
Escape and
No, but he was working.
now
Okay. Yeah. So as you can see on this angiogram, let me show you actually. So this is the left anterior descending artery. So here is tight lesion here, which looks like on the angiogram active lesion. these are the septals and the diagonals. Sure enough, he had, as the mid-proximal LAD, very tight lesion. And then so once we decide to put in a stent, one of the things we have to decide in the cath lab is whether to put in drug-eluting stent and bare metal stents. So as you know, most of our patients we use drug-eluting stents because they have low restenosis, low target lesion revascularization. But the problem is these patients, they need to be on antiplatelets for a year. So we got to make sure that they're going to be compliant taking on Plavix or the other antiplatelets. Otherwise, as you know, the risk of not taking platelet is stent thrombosis, which is worse than the one, it's a dreaded complication of one of complications of stenting. So this patient, we thought probably he may not be able to take antiplatelets for a year, so we decided to put bare metal stent. So we put in bare metal stent, 4 by 50 millimeter bare metal stent, and then he was discharged on dual antiplatelets, S inhibitor, and statin. So the next is why we choose drug-eluting stent or bare metal stent over the other. So before implanting DAS, the interventional cardiologist should discuss with the patient the need for and duration of dual antiplatelets and confirm the patient's ability to comply with the recommended therapy for DAS. So if we are not sure about compliance, we have to put the bare metal stent, because bare metal stent, they can easily endothelialize, so we can get away with antiplatelets for a month to 3 months. Or if patients are going for some scheduled surgery, we put in bare metal stent because we can stop the Plavix after a month or 2. But drug-eluting stents, we know they reduce restenosis and target lesion revascularization. And on different studies, they are superior to bare metal stent in complex lesion subsets. There is no effect on myocardial infarction, but there is very small increase in risk of stent thrombosis, late or very late stent thrombosis.
Sir, what percentage of our free care buy that medicine? All that medicine they put on. Do they not? Are they not?
Well, from like an absolute perspective, they won't be able to afford it.
Package.
So we do have that?
Yeah, we have packages that we can give them.
Medicaid pay for it?
They do, but they like obviously they would have to pay like a lot. But for free care, particularly, we've got this extra thing.
We can give them for 3 months. 3 months, we can give them free.
Yeah. So we got that worked out with the enrollment.
It's sad if you do all this work and they don't think it's
Absolutely.
Okay.
You know, the overall prognosis of these people, suppose that they do the right thing and everything, how is the survival to be expected of these people that they get treated? Because they're basically life cancer.
Yeah.
So, you know, if you have had cancer, you say, well, the possibility of survival in 5 years is so much percent. So, what is the survival of these people?
So what we do is, patients that we don't know their prognosis, especially terminal ear cancer patients, unless in the otherwise they have ST elevation with hemodynamic instability, we put them on medical treatment. But if they have ST elevation MI with head, then we took them to the cath lab, but we put in bare metal stent.
But I want to say, can someone study how long do they live, these patients? Or how long they will survive on these patients? Do you think they actually be dead?
Are you talking about the cancer or?
No. I'm talking about the patient with the cancer, these patients.
If they're probably going to continue
Yeah, so the thing is, it has shown it improves mortality and morbidity, no doubt about that, especially in patients with ST elevation MI. Now, these patients, most of the studies we have, for example, for 5 to 10 years. So if patients, for example, they have drug-eluting stent, their response rate is about 6%. So they come back for repeat revascularization 6%. If it's bare metal stent, it's about 30%. But there is no any mortality benefit between the drug-eluting stent and bare metal stent. They have the same effect on mortality.
I want to go back to later because this is a very educational case for all of us because we listen about this thing but we don't see it. You have brought to our attention something that you do every day and you're very successful, very nicely, and it's something that the chance of recurrence is interesting. So, but the literature supports when you say that the drug-eluting stents are better.
Yeah, no doubt about that. But now, the risk of stent thrombosis is 1 to 2%, okay, even in a year after a year. But the problem is when you have stent thrombosis, the mortality is 30 to 50%. That's why we get scared of stent thrombosis. So we have here a second patient. This is 60. So the patient we discussed is unstable angina. The only thing he had was EKG changes to invergence enzymes were negative. So it was unstable angina, part of the ACS. This second patient is case 2, 60 years old white male patient with history of heart failure and non-critical coronary artery disease on previous angiogram. And he came in with chest pain and he was ruled out for non-ST elevation MI with troponin of 30. So this is the EKG. Basically, it's atrial fibrillation, but he has some T-wave inversion, but his troponin was 13. So this one is what we call it non-ST elevation MI. So the difference between this patient and the previous patient is biomarkers, basically. So he was started on ACS management with aspirin, nitrates, statin, heparin, and beta blocker. And echo shows inferior wall hypokinase with AF of 35%. So I'm going to show you the angiogram. So you can see this is the right coronary artery again. You have tight lesion which looks like active with ulcerated plaque, the same as the previous patient. But the difference between the two is this patient has biomarker elevation. Otherwise, the approach is almost similar.
Can you point out this picture, please? Some of us see it.
Okay, so let me run it. Okay. So here is the tight lesion here.
So in the past patient, you saw a left.
Left anterior, yeah.
And this is a right.
This is the right coronary artery.
Sir, coronary dominance means which artery supplies the
Okay.
inferior diaphragmatic surface, which is usually most people have the right coronary artery dominance. But what does that mean?
Okay, I got. Let
What
me.
is the-
So the dominance is basically the dominance depends on the PDA. So this artery, so this is the right coronary artery. You have posterior descending artery that comes and gets collateralized with the LAD on the apex, and this is the PLV. This one is also with the circumflex. So this PDA, if it comes from the right, it's right dominant. Sometimes this PDA artery, it comes from the circumflex, we call it left dominant. Basically, it depends on this artery.
Does it matter? Does it matter clinically to you guys? No?
Yeah, what it matters is sometimes when you have patients, with small right coronary artery, even if they have lesion, they are supplying very small area of myocardium, so we don't do anything.
Okay.
So we don't do anything.
I
So
know that the majority of the people have right coronary.
most 80%, 85% of them, we have right dominant coronary artery. So if it's left dominant, what happens? What happens is, it comes from the circumflex. So you see, this thing comes from the circ. So we call it left dominant. So this is the same right coronary artery in different image. Lesion was so the lesion was here. So we put in a stent and
Very nice.
so discharge.
How hard is to catheterize the coronary arteries? How hard is it?
It's not hard. A little bit the right coronary artery is a little bit, but the left, the catheters are preformed to engage the left coronary sinus in right corner. So it's not very difficult. The only thing is sometimes we have what we call it coronary anomalies. They don't come from the normal area we expect, so we have to use different catheters. So the right coronary artery can come from the anterior aspect of the aorta. So in such case, we have to use different catheters to engage. Otherwise, it's not difficult to engage the coronaries. Okay. Okay. So this is case number 3. So we have done unstable angina, non-ST elevation MI. This is 44 years old black male patient with past medical history of hypertension and smoking. Presented to ER with chest pain with radiation to the left arm and jaw. And this is the EKG. Probably most of you are familiar with this EKGs. This is ST elevation in the anterior and lateral leads, all the way from V1, V2, V3, all the way the lateral leads. So this is basically the left anterior descending artery, ST elevation MI. So these patients, our standard of care is, to reperfuse the artery within 90 minutes. To reperfuse the artery within 90 minutes. In our setting, we don't use any thrombolytics. We use catheter-based intervention. So patient was given aspirin, Plavix, heparin in the ER. And here is the angiogram. So if you see, this is the left anterior descending artery. So it's cut off here on the proximal. So it was supposed to come like here, all the way here. So this is what we call it ST elevation MI. So basically ulcerated plaque, thrombus in the obstruct. There is no flow. There is no flow. So that's why these patients, they need emergent left heart cath and revascularization. So the standard of care is 90 minutes in our setting. If they are somewhere in the countryside, they don't have cath lab, they have to give them thrombolytics. So you can see how big the artery is. It was occluded here, where the diagonal branch was coming. Here, so we put in a stent, and this is see how big myocardium is supplying. So when we do case these patients, we do thrombectomy. What that means is we aspirate the thrombus first, and then we do balloon angioplasty, and we put in drug-eluting stent. So the dual balloon time is 73 minutes. We have to register that on every single patient because it's one of the quality control issues patient should be reperfused within 90 minutes. Every time, for some reason, if there is delay, if it's above 90 minutes, we get quality control issue letters from the department, from the administration. So why we open the artery? So this is a very important slide. Time is the essence and time is muscle. So this is a mortality reduction and myocardial salvage. So the first an hour and a half is the critical time for these arteries. If we open it up, we can salvage a lot of myocardium. But after 3-4 hours, you see the benefit is not as dramatic as the early phase. That's why the standard of care is 90 minutes. So critical time dependent to open the artery, but after 4 hours, the benefit they get is not as good as when we reperfuse them early. But again, there are different school of thought. Even after 3-4 hours, there are people who think open artery is good anyway, so they want to open the artery. But some people, they say there is no point if they don't have symptoms, no chest pain, normal EF, not to do anything. But most of the time, these patients have residual chest pain, they have low EF, so we end up opening the artery anyways, especially when it's within 12-24 hours. So myocardial reperfusion, initial primary PCI, fibrinolytic therapy. So if you, in the countryside where they don't have cath lab, they use fibrinolytic therapy. Acute surgical reperfusion, very rarely, if we are not able to open the artery, we can refer them for bypass. So these are the guidelines. STEMI patients presenting to the hospital with PCI cover should be treated with primary PCI within 90 minutes. STEMI patients who present to hospital without PCI capability, they need to be given thrombolytics. If they cannot reach to balloon to cath lab within 90 to 120 minutes. So most of the patients we get, if it's from Ruston, Conway, all those places, either we tell them to take them to the nearest hospital or give them thrombolytics and transfer the patients, because it's going to take time for those patients to transfer here. And these are the indications for thrombolytics. Early presentation, less than 3 hours. If there is delayed invasive strategy, prolonged transport time, or cath lab occupied or not available. Actually, this one, in our setting, we use the other lab. But if the door to balloon more than 90 minutes, sometimes they say 120 minutes, then those patients should be given thrombolytics. So why we choose balloon-based treatment than thrombolytics? So this is the meta-analysis of 23 trials, days, recurrent MI, CVA, and everything. PCI outperforms thrombolysis. That's why that's our, standard of care for any patient with ST elevation MI is to do balloon angioplasty and stenting. Because if you remember the first slide, the ulcerated plaque, there is plaque there. Even if you give thrombolytics, it can take care of the platelets and the antithrombin, but still they have ulcerated plaque. That's why that needs to be treated. So on the studies that has been done, patients who receive thrombolytics, about 50% of them, they have significant residual stenosis, and about significant number also, the arteries, it may not reperfuse. We call it a failed thrombolysis. So those patients, they need to be, shipped if they are in the countryside. So PCI outperforms thrombolysis on days, recurrent MI, and CVA. So this is case number 4. This is 56 years old black female with history of hypertension, lung CA on chemo. She has esophagitis due to radiation with subsequent candidal esophagitis that was treated with nystatin, present with sudden onset chest pain with radiation to the back. And this is the EKG. As you can see, she has inferior ST elevation. And we took her to the cath lab. So if you see, there is ulcerated plaque and thrombus here. Even though, you know, she has still flow, sometimes such lesions, they can show up with ST elevation MI. Basically, it's threatening to shut down. So there is thrombus here and ulcerated plaque. So since this patient had cancer and, you know, esophagitis, she has increased risk of bleeding. So we put in bare metal stent. So this is, you can see, this is the area we cover with bare metal stent. But the story didn't end there. So she was discharged on aspirin, statin, and beta blockers. But 4 days, but 4 days after discharge, the patient came back again to the emergency room with chest pain. This is again the EKG. So 4 days after intervention, and she came with again another ST elevation MI. So basically, this is stent thrombosis. So I will show you the angiogram. You can see this one is worse than when she first came in. So this is completely occluded with stent thrombosis. So stent thrombosis is one of the dreaded complications of coronary stenting. And the commonest cause of stent thrombosis is non-compliance. Patient doesn't take antiplatelets. But there are also other lesion characteristics that can increase the risk of stent thrombosis.
Did this patient not take her medicine?
Well, what happened was apparently she thought she was allergic to aspirin, and she was not taking aspirin, but she was taking Plavix, and within 4 days she developed stent thrombosis. Most of the patients are patients who are non-compliant patients who present with stent thrombosis. And I will show you, see all this thing here, all this is thrombus here. So, and then we have to remove thrombus with aspiration device. And the doctors who did this, they felt maybe sometimes if we have a gap didn't cover the lesion, or when we put in stent, if there is what you call a stent edge dissection, then we have to cover that dissection with stent. So that's what they did. They put in another stent here. They were not sure whether she had any stent dissection.
If you ever get an infected stent, there's nothing you can do about it, just the antibiotics?
I don't know how you're going to prove it. I don't know how you can.
You can't pull it back out, can you?
Well, the stents, these
They
stents.
go and cut it and then do a bypass? And all of your stents are all MR compatible and everything?
Yes.
Stents are all MR compatible, everything is?
Yes.
So these are some of the conditions associated with increased risk of stent thrombosis, dual antiplatelet discontinuation, patients with diabetes, acute MI patients, low EF, renal failure, and we have some lesion subsets, bifurcation, longer stent lengths, and the residual dissection, and stent malapposition. These are the conditions, lesion characteristics, and patient characteristics that can increase the risk of stent thrombosis. This is the last patient I have. This is 55 years old, black female with history of hypertension and pancreatic cancer, which was not unresectable, and they did gastro and hepatojejunal bypass and celiac plexus block. And patient had history of recurrent CD gastroenteritis. So she presented on 5/31/15 with diarrhea and abdominal pain, and this was due to C. difficile, and at the same time she has some chest pain for 2 months, which gotten worse 2 days before cardiology was consulted. So this is the EKG. You can see this EKG. She has anterior ST elevation V1, V2, and some on V3, V4. So basically, we took her to the cath lab, and so basically, this is the left system. It's normal coronaries. We shoot also the right. It's normal coronaries. But when you see the EKG, we expect to find something on the LAD, but arteries were normal. So we see these patients maybe once into 3 months who comes with ST elevation MI, looks like acute MI, but with normal coronaries. And I'm going to show you the next. So we did angiogram. Okay, if you see, I was trying to show you, there is this syndrome, we call it now stress-induced, cardiomyopathy or Takasubo disease. So we don't know the reason, but patients with the present with ST elevation MI, the coronaries are normal, and first was described in Japan, and now we're seeing a lot of patients who have stress, whether physical, mental, present with what we call it stress-induced cardiomyopathy. So the characteristic is, we call it apical ballooning. So the apex balloon, but the base contracts very well. Maybe this may interest you for you guys who are in the basic science, because so most people, they think this is catecholamine induced. So there are different names for this one. We call it apical ballooning syndrome, broken heart syndrome, Takasubo cardiomyopathy. This is the name is from Japan. It means octopus trap. So the shape of the octopus trap, look, it's called Takasubo in Japanese. So they call it Takasubo cardiomyopathy. First described in Japan and was subsequently reported in the US and Europe. The term Takasubo is taken from the Japanese name for an octopus trap. It's triggered by an acute medical illness or by intense emotional or physical stress. So it's a syndrome of reversible ventricular systolic dysfunction precipitated by acute emotional or physiological stress, can mimic an acute myocardial infarction, believed to be sympathetically mediated, but precise pathogenesis is unknown. Possible mechanisms: epicardial spasm, microvascular dysfunction, acute plaque rupture, vasospasm, or direct catecholamine mediated myocyte injury. And this is what they call apical ballooning. So you can see the base is contracting very well, and the apex is severely hypokinetic. And we cannot describe it with coronary anatomy, because this area is supplied by LAD and this area is supplied by RCA. So it's not, so the whole area on the apex and the inferior wall and anterior and the apex is hypokinetic. So that's why some people, they think maybe this is vasospasm of all the coronary arteries because of stress. So helpful but not required, an acute trigger, characteristic is ECG change. They have ST elevation on the ECG. They have mild elevation of cardiac enzymes. On this particular patient, her troponin was 1.6. In patients with acute anterior myocardial infarction, we expect, very, high troponin value. On this one, it was 1.26 only. And they don't have, they have elevated troponins, but not much. So these patients, actually, they recover within 2 to 3 months. So the treatment is acute supportive care for heart failure with beta blocker and ACE inhibitors. One of the things on these patients, different from the other patients, we manage patients with cardiomyopathy and cardiogenic shock is by giving inotropes. But some of these patients, actually, they may become worse with inotropes. So we don't understand the mechanism, but because the mechanism is presumed to be sympathetic mediated, some of the inotropes, they may worsen, the cardiomyopathy and the hypotension of the patient. So we have to be careful on these patients. The only thing we can give them is beta blockers, S inhibitors, and aspirin. I think that's what I have. If you have any questions.
You guys, seniors, are there any things that were on your boards that related to this we could ask questions on? He said this was absolutely fantastic. He really wanted to thank you. He wanted to thank you, and this is really helpful because we don't know a lot about this.
And the only cardiac stuff we have CTA and MR.
How often, they're almost all those big ulcer plaques, restriction or proximal, how often are they distal?
How often they are distal?
Just distal. How often?
Well, what we see is sometimes you may not see it on the angiogram, on the ulcerated plaque, they have thrombus. So when we put it with the wire and catheter, it may migrate distally. But we see also distal LAD, distal RCA. We can see ulcerated plaque anywhere in the corners.
Are they usually proximal?
No, we see it everywhere.
All the ones you showed were pretty much proximal.
Yeah, because these ones are the big ones for you guys to see. But we see ulcerated plaque. Yeah, so we see.
We don't fix.
It's very small vessel,
Yeah. Our smallest census.
Yeah.
Okay.
That's a bare minimum. Smallest structure is 5 So the vessel is like really small. That's of that things, we usually use medical care for everything that we do, like excellent in the acute setting, but also substrate method. You guys always process, it's kind of like this, and also again, if you don't scaffold with the stent, so there's no point of opening up all the blood vessels.
So for the cath lab crew who came in late, we have lunch here. And for some of the guys, we have still lunch here. So.
Thank you.